Good evening. Welcome to this group discussion on abdominal trauma. I have deliberately called it a practical approach. It's a very vast subject. Honestly, I don't think anybody can cover it comprehensively in 1 hour, even if it's a didactic lecture and not a discussion. Of course, discussion takes longer. And so, what I have planned to do is give you an overview. I may even go about 10-15 minutes over time. Hopefully, I'm not, but I'll try to keep it short, but basically give you an overview of what you should know. And my primary concern is you as residents, as trainees, and maybe very young surgeons and registrars, when you are called to the casualty to see a patient who is injured, particularly abdominal injury, what are the principles you have in mind? What can be termed as surgical pearls, which you have to remember and do. And that is the kind of approach that I have in this PowerPoint. Everything, of course, is heavily evidence-based. If you guys are interested, you can write to me and I can send you all the references. But honestly, at the MSDNB level, I mean, registrars may want to read more, but MSDNB level, I don't want you to strain too much reading a lot about it because you have so much more to cover, in all other areas. So if you just understand what you need to do when you see a patient with a casualty, this talk would have, or this discussion would have done its purpose, served its purpose. Okay. It's a leading cause of death in young people. That's for sure. Mortality at a conservative level is 2 to 10%. That's in the West, where they have very advanced trauma and triad systems. They have full blast community systems and paramedical staff and all that. I suspect the mortality is very much higher in India, but even though I don't have solid data to say that. But everywhere, with the laying down and following of protocols, things are improving. But the important thing is that all of us must know what these protocols are and what the drill is so that we keep the mortality to a minimum. First pearl, abdominal trauma does not occur in isolation. Most of the time, unless it's a stabbing into the abdomen, uh, most of the time it's a road traffic accident or fall from a height or whatever. When that happens, it's always multiple trauma. It's never in isolation. So that the first thing you must have in mind, somebody comes to the casualty, tells you, I have pain in the stomach, and you just don't go and see, see the stomach in isolation. I had a dramatic case. I was a registrar. I was between operations in Aberdeen when my SHO called me and said, this young lady who has some abdominal distension and she is in pain. And so please come and see. And she seems to have, a systolic of 100, but there is no tachycardia. And she's comfortable in herself, even though she has some pain. And when I go there and just as a very casual thing, because it was drilled into me by that time that we have to do everything, can you please move all your limbs? So she could easily lift her right upper arm, left upper arm, and could not move the lower limbs. She could not even lift it. I said, are you sure? I mean, everything looked perfectly okay. She had no back pain, no symptoms referable to any kind of injury to the back. But what she had was a paraplegia at that point in time. And then I wondered whether it was quadriparesis. And suddenly I said, please put a collar right away. But it wasn't done. The patient was already in the casualty for an hour or so. We put a collar. Of course, eventually we investigated her and found that she in fact had a fractured neck, but luckily had not involved her upper limb, but lower limb was gone, which was very strange, very unusual. But perhaps it had to do with the kind of areas, but she recovered. I mean, it was probably apraxia. But the thing that we had to do was to look at her in totality. And the discomfort and the distension she had in the abdomen was because of her back injury. And so I was thanking my stars that it was drilled into me to look at the whole patient. That I start with a story true story, because it is something all of you must have in mind when you go to the casualty. I will not talk about pre-hospital care. That's a huge topic by itself. And as I mentioned, we know about the golden hour after trauma. most of the improvement in mortality that people have achieved in the West is actually because of pre-hospital care. Okay, even though there's a nice drill in the hospital as well, but please remember that most of the advancements or the improvement in mortality is actually because of pre-hospital care. And sadly, in this country, we lag far behind the West, and we really have to do something about it. But when we come to the hospital, we look at two classes or two scenarios, broad scenarios. One or two or three or four patients coming together in a busy casualty. You will have two or three registrars and maybe even one person who can quickly look at all three. But you also have mass casualties. In a big accident somewhere, pile up on a road or plane accident or something like that, you'll end up with 20 to 30 people. Okay, and you're called to that situation. That's when triage comes into being. All right. So we need to understand what a triage is in very basic terms. Vinod, tell me what a triage is.
Sir, basically, when there is a mass casualties, generally we do this triage because to make the important patients prioritize first. In that, we color code the patients.
Yes.
Basing on that, red, yellow, and black will be given to the patients.
Okay. What is black?
Dead patients are called black, sir.
Yeah, or nearly dead patients.
Nearly, yes.
Yeah, this is it needs a lot of experience, but many times I have been called into this situation as a young, trainee surgeon, and I found it very difficult to decide this. Even experienced surgeons find it difficult, but it's a thankless job, but you have to do it. So the main areas are, red indicating priority. These are life-threatening situations, but which can be salvaged. Okay. Yellow is not life-threatening, but still a serious injury needs hospitalization. Green is walking wounded, as they say, minor ones, they can wait for 2-3 hours. The yellow ones usually can wait for an hour or hour and a half or something like that. But the red ones cannot wait. They are the ones who need priority. And the black, nearly gone, you can't help them. And so you don't, it's very sad, but you don't, spend too much time. Keep them comfortable, keep them pain-free, comfortable. That is triage. And trying to make it a little more, scientific rather than just arbitrary. And, people have done a lot of scores. There are many scores. Nikita, any idea how many scores are there? And can you give me some examples of trauma scores? Is she there? I don't see her. Go on.
Yes.
Yeah.
Sir,
Just mention how many trauma scores do you know of?
Sir, trauma and injured severity score, sir.
Okay.
And revised trauma score.
Okay. 2.
The
Yeah, it's crazy. All right. It's crazy because none of them is satisfactory. So even though people have tried to get some kind of a objectivity into these scores. Okay, the purpose of these trauma scores basically is to classify patients. It puts your triage, for example, on a more scientific footing, very difficult still. It prognosticates. You want to tell the family, how the patient is going to fare. It helps. Quality assurance at a departmental level audit, for example, you have the same degree of scores, injury, and then see how the outcome is. Research is important. And for payees, when you have to bill them, you can then have some kind of objectivity. These are the purposes of a trauma score. And as I said, the examples are mind-boggling. You have 5 or 6 in each category, and there are 3 or 4 categories of classifications. At a physiologic level, for example, you can talk about a revised trauma score, Apache, SOFA, SIRS score. At an anatomic level, ISS that Nikita mentioned, new injury severity score, anatomic profile, another one for penetrating trauma. All right. And there are combined ones, injury severity, TRIS, trauma score, injury severity score. You can go on and on. Okay. But the point is, there are so many of them that perhaps none of them is right. And so as a department, as a group, each of us has to decide on one score. learn it and actually practice it when you see these trauma patients. And this is what I would recommend because it's the simplest. It's called the revised trauma score, which combines GCS, the Glasgow Coma Scale, the systolic blood pressure, and the respiratory rate. The simplest of three things that you want to do. Each one has a coded value. The better it is, higher is the value. So at the end of the day, when you sum up these three things, if you have a lower score, higher is the severity and worse is the prognosis. This seems to be a very simple thing, and I would recommend that all of you make a copy of this and apply it when you see your trauma patients. We don't see a lot of trauma in Sagar, but even if the occasional one that you see, I think it's good that you apply it. And if in future we have more and more patients, we can have research project based on this. Okay. And so once you see the patient, once you triage them and you're looking at them in terms of treatment, we go through the classical primary and secondary survey. All right, Samir, what do you do in a primary survey? Is he there?
Hello?
Yeah, go on.
Yes, sir. Sir, we look at the ABCD, sir, airway, breathing, circulation,
Very good.
disability, and exposure.
Yes, good. So what else? Each one of them, what are the things you're concerned about? What's the difference between, if I tell you, what's the simplest thing that you do to make sure that the patient is not very badly injured?
Sir, C-spine for airway, sir.
Don't worry about spine, this and all that. Just you see the patient straight away. What is it that tells you that the patient is seriously injured? What am I saying there? First one, upper left corner. Sorry? Go on. Samir. Phonation. What is that? Is there a problem? You're muting yourself? Ines, why don't you take over?
So how the patient is responding, sir, the
And the
responsiveness of the
patient
patient
speak.
and
the
the
patient
vital.
speak. Okay.
Yes, sir.
So if you say, what's your name? What happened? Where are you? If the fellow can speak, it tells you that his mentation is okay and that his voice box is okay. Okay. And his pressure is okay. Otherwise, if there's no circulation to the brain, he will not be able to talk. So phonation is a very, very simple thing that tells you if somebody cannot speak, then your antenna must go up and you look at these three things. Airway maintenance, look for foreign bodies, tongue falling back, breathing and ventilation, circulation. All this is very clearly known. I'm not going to go into it in depth, but that is the first drill, even in abdominal trauma. And I'm going to say this a million times in the course of the next 1 hour. What is important is repeated examination. You cannot, when you go in there, I have proved it to myself several times in practice. Repeat examination shows something else, which will sometimes radically change your approach. So repeat examination every half an hour is very important. You see the patient first and then advise a few things. And when you're going away, and you come back in half an hour, 45 minutes, and see him again afresh. See him again afresh, ask the same questions again. Make sure that a repeat examination is diligently done. All right, that's an important thing. We then go on to, as soon as you have a quick primary survey, you maintain these. These are the things that we do. Just a recap. I'm sure all of you are familiar with this. Good venous access, either a central line or two peripheral accesses, pulse oximeter, ECG monitoring, blood gases, Rayleigh tube, and catheter. Catheter, there are certain caveats. If you find blood in the urethral meatus, then you need to think twice about it, not blindly put it in. If you have oropharyngeal injury, you do not put a Rayleigh tube in blindly. But generally, most of them will not have these things, and this is important. And while this is going on, you organize a chest X-ray and a pelvis X-ray in the department. Don't send them away in the emergency department. Don't send them away until you're very sure that they are stable. And if facilities are available, then and there, an E-fast or a fast. We'll talk more about it. What is secondary survey, Ines?
Basically, you take the history to find out the mechanism.
So what is the difference between primary and secondary survey? You're actually right, but I need to know, I need you to go in a systematic manner. When is it done, for example? Soon after resuscitation. All right?
Usually
Yeah. Do a primary survey, do resuscitation, all the steps that we mentioned, IV fluids.
First,
Your
you
voice is
do
breaking.
everything to. Yes, sir.
Voice is breaking. Where are you? Or do you not have a good connection? Go on, try. Otherwise, we'll go to somebody else. Yeah, I think we have a problem with the connection. All right. Praveen, tell me about secondary survey.
Sir, after resuscitating and patient vitals are stable,
Yes.
stabilizing them, we'll take the history, head-to-toe examination,
Yes.
and pain
So
management.
the stress there is a detailed history. Okay. Detailed history, head-to-toe examination. You're quite right. And again, repeat as needed. And why is history important? Ample is the mnemonic people use. You must know about the medications they're on, allergies, past illness, and possible pregnancy. Sorry about this. Sorry, I usually turn it off, but I didn't today. Sorry about that. Okay. And the last meal, very important. If you're intervening somewhere, you need to know what it means. Events and environment related injury. Okay. This is very, very important. Can you tell me why this is important, Praveen?
Usually those are not seen by us.
Sorry?
We'll be neglecting it.
Why is it important?
Usually-
Why do you need to know about the events and the environment related injury?
Sir, in the primary survey, we'll be usually neglecting it, sir.
No. In secondary survey, why do you do it? You're not neglecting it. You don't have the time to
Yes,
do
we
it,
have-
okay?
Yes, sir.
You
Yes,
know
sir.
it has to be done, but you're not wasting time on it because you're keeping the patient alive. In a secondary survey, as a deliberate move, you look at events and environment. Why is it important is my question.
To know the cause of injury, sir.
mode of
Cause-
injury and to look for
Something
other
like chemical injuries or these things
The
we can treat.
word is mechanism of injury tells you a lot about what to look for. That's number one. That is to protect the patient. Second, if there are environmental hazards, you have to protect yourself. Toxic substances, for example, something like that in the area of the accident. You need to perhaps have an infected environment. You perhaps will have to quickly switch over to a PPP or wear double gloves and things like that. So it's important for you to know where it happened, and that happens in the secondary survey. Okay, that is the important. So what is a tertiary survey? Nitya, when does it happen and what does it show?
Sir, it's for the definitive management, sir.
All right. When does it usually take place? Temporally, in terms of time.
After complete stabilization, sir. Like after the
After complete stabilization, it is secondary survey, after resuscitation. Either you can stabilize or not stabilize. You do something if you cannot stabilize. If you stabilize, you do a full secondary survey. So when does the tertiary survey come into the picture?
like a minor injury or something that which has
When
been
does it
missed
come
out.
into picture is my question. Specific question. When do you do it? On the day of injury, next day, subsequent day, after discharge? When does it happen?
Almost
discharge,
closer to the
24
discharge,
hours
sir.
of-
No, it's usually 24 hours after injury. All right. And as you rightly said, the missed injuries are what you're looking for in a tertiary survey. All right. Missed injuries are classified into type 1, type 2, type 3. Just for you to remember. Type 1 is something which you pick up after secondary survey, but within 24 hours. Type 2, after secondary survey, but after 24 hours, but still within the patient's hospital admission, not after the discharge. And type 3 is after hospital discharge. You know, when you come for follow-up, you may miss something small. So you can pick up injuries. 15% of cases is a very conservative estimate. Sometimes 50% of these injuries are missed even after a secondary survey. All right. It's not that people were lackadaisical or didn't know about it. The fact is that it can be so complex, but please remember, these are not major injuries. These are small injuries, perhaps an ankle sprain or an abrasion somewhere, or a small fracture of a metatarsal or a phalanx or something like that. But nevertheless, these are important to document and treat. And so a tertiary survey is something which you have to do, which means that you may have to repeat all the examinations, clinical examination as well as investigations, x-rays, ask for more x-rays, for example, some swelling of the foot which you might not have seen on the first day. The first primary and secondary surveys put together is called initial assessment. Okay, so after the initial assessment, if you have not, if you have not seen something and you see it the next morning, for example, maybe you want to ask for an X-ray of the foot or something like that, or an X-ray of the ankle if there's a swelling. So things like that, tertiary survey is something that you do. Mind you, I'm doing all this even though my topic is abdominal injury, because it is never seen in isolation. And if you have a significant abdominal injury that we have attended to, these things become all the more important, because you will not be giving your attention to these other things. Also, in multiply injured patients, if the head and the lower limbs are injured, or the chest and the thigh are injured, for example, take it for granted that there's an abdominal injury. Whatever caused this combined injury will damage the organs or the area of the body in between these two areas, in between the two injured areas. And so your antenna must go up and look at that. And if there are multiple injuries, prioritize care. Just like I mentioned about triage, which is not easy even in experienced hands, prioritizing care in a multiply injured patient needs a lot of inputs. One person cannot, there are some situations where the answers are obvious. Now, if you have a patient who has a significant head injury and coning, for example, obviously the decompression there must happen. If somebody has a fractured neck and getting into quadriparesis, that has to be stabilized first. But if you have at the same time a major vessel injury, aortic injury in the abdomen, perhaps both have to be done together. All right. But if you have or if you have tension pneumothorax, that needs to be prioritized. So whatever you think is life threatening has to be dealt with. But note that other than a major bleed in the abdomen, even a bowel injury can wait a few hours, whereas a tension pneumothorax or a coning head injury cannot wait that many hours. So that is the kind of prioritization. So it's always good to have more minds working. And the only solution that we as a profession can have is to have multiple specialists, even in the same field, may have a couple of trauma surgeons or general surgeons, have a couple of orthopedic surgeons, a couple of neurosurgeons. All of us get together and see what is best for the patient. That is the only way you can do that. And I keep on saying that repeated clinical and imaging assessment is very important. A single assessment cannot, you may miss something on the first X-ray itself, but more importantly, new things happen. When there is a bleeding in the abdomen, the very first X-ray you take as soon as the patient comes may not show that much of a bleeding, but you repeat it an hour later, you may see a much bigger bleeding. So you get a sequential idea of what's happening, and that is important for you to note that. Okay. Can I stop here now for a bit and then ask for comments? Srikanth.
Nothing much to say.
All right. Niranjan.
So nothing, sir.
All right. Ravi.
No, sir. I think it is, going according to plan.
All right. Okay. Thank you. So abdominal trauma can be, I'm now coming to the specifics of abdominal trauma, having dealt with the general aspects that you have to have in mind. Blunt and penetrating. These are the two main classes. I'm going to deal only with practically the whole of the class with blunt trauma. I have just one slide on penetrating trauma, which I'll give you a very basic outline. But as I said, if you want, we can have another class on details of individual organ involvement and penetrating trauma and things like that. It is sensible to understand blunt abdominal trauma because most of the abdominal trauma, 80% of it, is a blunt injury. Now, what is the history that you think one should take when you have, we are looking at a patient who is compos mentis, who is not, who's generally stable, who can talk to you, but has a trauma. What would you focus on? Or if the patient is unwell, maybe there is a knowledgeable attendant who can come and give you the history. What would be the things that you would ask for? Vinod.
Impact. I mean, the source of impact and where is the impact?
Mechanism of injury is one. Yeah. Okay.
And times, duration from the time of the
Yes.
impact.
Yes.
And any pain. Patient has any complaints, specific complaints about abdomen?
Okay. Pain. Yeah. Okay. There are two main headings. One of them is the mechanism. The other one is the medical legal implications of that's something which always you must have in mind when you're dealing with trauma. Okay. There's always a medical legal angle to it. So in the mechanism, it is important, in terms of symptoms that you're trying to say, I agree, pain, distension, vomiting are the three main things that you ask for. But I was looking at more generalities here. For the medical legal thing, whether you can get a consent from the patient or not is the main thing in the history. All right. If the patient is not compos mentis, is very confused, very ill, consent is an issue. What should you do then is something that's a subject of a different, for different talk, but I won't go into it now. So that is something that you have in mind. If you have a mechanism, there are only three things that can happen: a direct impact, a shearing force, and an acceleration deceleration force. Now, how is this important, Vinod?
Sir, this acceleration deceleration is generally more important in brain injuries, sir, because these lead to.
Where does it figure in the abdomen? I agree. It's important in brain, but it's important in the abdomen also. Where does it come in the abdomen? All right.
No, sir.
Kind of like seat belt injuries.
Sorry?
Seat belt injuries.
Yeah.
Same
So
like whiplash, but in abdomen.
what are the organs that are involved mainly?
Duodenal flexions.
Something, you're sort of vaguely there, but not really there.
Mesenteric.
No. Shearing force is where the mesentery is involved. Direct crush is what? What does the bowel get crushed against? Against the vertebral column. Okay. Particularly when it happens suddenly, you're not having when you know that an injuring force is coming, you tighten your tummy as a reflex. And that actually saves you because the tight abdominal wall absorbs quite a lot of impact. But when it happens suddenly, the anti-abdominal wall is relaxed. So direct crush, that force will crush the bowel against the front of the spine, and they end up with a lot of lacerations and contusion injury. Acceleration, deceleration classically occurs with solid organs, which have retroperitoneal connection. All right. So when you have the sudden deceleration, there is such a jerky movement that liver, for example, can get torn at the level of the hepatic veins. The spleen can get torn away from the diaphragm, and that can impact a lot of, it can, in the same process, can impact many vessels, including in the hilum. So that is the acceleration, deceleration. Basically, many solid organ injuries, in addition to direct crush, also are impacted by deceleration injuries. Okay, so what do you focus on in physical examination? Nikita.
Sir, first the general status of the patient.
Yes, abdomen. We have talked about it, airway, breathing, and all that. In the abdomen, what do you focus on?
So any discoloration on inspection, any discoloration, distension.
Yes, good.
And, any external injuries, sir.
Yes.
And on palpation, tenderness and rigidity guarding.
Right.
And
Percussion.
yes, percussion, like any. Can we?
Yeah. You can percuss. If you have a lot of blood, you can get dullness like just like a free fluid. Or if there is a hollow viscous perforation, you can have a loss of liver dullness, for example. There's a big pneumoperitoneum. So these are the things, external marks are very, very important. Staining, the so-called flank staining of great ulnar and the periumbilical staining of colon, these are time-tested signs, but are extremely rare. I have hardly seen them except as photographs in textbooks. Okay, but the two things that you do is gentle compression. Gentle is the operative word. Just gently press on the sternum to see if there is any pain, to suggest, rib fractures, and then compress the pelvis to see if there is any pelvic fracture. A crepitus in the lower chest may suggest a possible pneumothorax with a leak of air. Always important to see the back and the perineum and rectum and vagina. This is something that's commonly missed, but when you do look at the back, log rolling is important. All of them must, by force, compulsorily must have a neck collar, and you must, if you want to look at the back, it has to be done by others in the form of log rolling, and then you inspect the back as well. So that is important, but this is what is something we have to realize. This is very unreliable, very unreliable. Not that you should skip it because it's unreliable. You must do it because something that's gross will be seen. But if nothing is seen, it doesn't mean that there is no injury. There is no significant injury. That is something that you have to bear in mind. Fast has become a very standard procedure now. Surgeons must be doing it. I regret the fact that I don't do it myself. It's probably not too late. All of us must learn doing it. But we're not doing it because I think by and large we'll get our radiology colleagues available round the clock. And so that is the standard of care now. It's a part of your clinical examination almost. Okay. E-fast compared to fast is so-called extended fast. It includes a pulmonary window, which will look at pneumothorax. Otherwise, a standard fast is an epigastric window, number 1. Number 2 is the right upper quadrant. Number 3 is the left upper quadrant. Epigastric window is your pericardial window. You want to look at the pericardial hemopericardium, for example. Number 2 is the right upper quadrant. 3 is the left upper quadrant, living at liver and spleen respectively. Number 4 is the pelvic window. You want to look at the pelvis. So, Sanya, tell me something about fast, how reliable it is, where are its fallacies, how much importance you can give it.
Sir, ma'am is an emergency, sir.
Ma'am is emergency. So
Yes, ma'am.
Nitya can do the honors. Yeah.
Sir, basically the advantages would be it is quick and also it is non-invasive, and but it is operator dependent. So
Yes.
certain injuries like bowel gas shadow could be one of the it can obscure the other underlying find.
Are you even looking at bowel at all in fast? What are you looking at in the fast?
Basically, we are looking at for solid organ injuries and peritoneal, pelvic or peritoneal fluid, free fluid in the
Not even solid organ injury. You're looking for fluid everywhere.
Collection.
Right upper
Yes.
quadrant, left upper quadrant, pelvis and pericardial cavity. That's all.
Pericardial. Yes,
Looking
sir.
for, yeah. So what else? Yeah, how sensitive or specific is it?
Sensitivity.
Okay. You need to have at least 150, 200 ml of blood in the peritoneal cavity or even
Yes.
bowel fluid. You cannot differentiate between the two. Okay, if there is it's a hollow viscous injury and bowel content, you cannot differentiate between the two. But it's about 80% sensitive. It can miss a few, but it is very specific. Once you see it, and in hypotensive patients, it's 100% specific in the sense that they've had a significant bleed. Not 100, 200 ml, maybe 1000 ml bleed. So it's a large quantity. It is almost never that you miss it. Okay. So in hypotensive patient, it reaches a very high specificity. Repeat examinations will improve your sensitivity. It will reduce the false negativity. But please note that even in this day and age, even with good people doing the fast, a negative result cannot rule out trauma. Okay. And nowadays, it's also employed in non-traumatic hypotension. Okay, so that is something that is a part of the so-called rush protocol. One of the important areas where it helps you is in an injured patient, you can have distension. If he's injured, he may not be able to respond to pain. He may be semi-comatose with a head injury, with a spinal injury, in which case, and they also have abdominal distension. Because they're comatose, you're not able to assess the so-called guarding and rigidity, which is very unreliable anyway. So in those patients, the distension is because of an ileus. So if you can rule out that there is no fluid in the abdominal cavity, then you would give your attention to the spine and the head rather than the abdomen, even though there is abdominal distension. That is where it comes into, being, as I say, it's a very important part. The diagnostic peritoneal lavage was something that, we were doing as a routine when we were training. Fast was not available in those days. It's a more recent phenomenon. But if you do not have fast, there are many areas where you may not find an ultrasonologist. You may not be trained yourself. So DPL is not something that is completely redundant, even though in the era of fast, DPL is disappearing very fast. Okay, so what do you do in DPL? Ainash, Praveen can tell us about it.
Sir, first we'll insert trial strip to decompress stomach, sir. Then
Okay.
Foley's to decompress bladder.
Good.
Then needle will be inserted just below the umbilicus, sir, and
Okay.
will aspiration.
Mhm.
If it is greater than 10 cc of blood comes out, then DPL positive.
Mm.
If doesn't come out, then we have to inject 1 liter of NS oral
Okay.
and we'll aspirate it, sir. Based on
Okay.
that, if RBC is greater
You're
than
only
1
putting a
lakh,
needle or something else. You can't have a sharp needle sticking into the abdomen when you're doing all these maneuvers.
Like Venflon, we can put it, sir.
Yeah. Is it a Venflon or something better than that? If your tube is longer and sitting somewhere in the pelvis, it will be a lot more sensible.
Like an CVP catheter.
Peritoneal dialysis
peritoneal
catheter.
glands. Yes,
All right. Use a peritoneal dialysis catheter. Put it in the subumbilical area and push it in towards the pelvis. Then you aspirate. If you have either blood or bowel contents coming out, frank blood and bowel contents, you have the answer straight away. If you do not have it, then you put a liter of saline into it and then you aspirate again. And you may not be able to see things very clearly, in macroscopically. But if you have a large blood RBC count or a WBC count, or you get organisms on gram stain, then you know that it's a positive DPL, and then you need to then look at what you need to do further. All right. Now, there are certain contraindications, and these essentially mean that there's something happening in the abdomen before the trauma, which means, advanced stages of pregnancy, abdominal scars, or extreme obesity, where you cannot find the peritoneal cavity easily. These are the limitations. But as I said, the role for DPL is very, very limited nowadays. Now, we keep talking about saying, stable and unstable patient. What do you mean by that in very simple terms? Samir?
Yes, sir.
What is an unstable patient according to you? Okay. He's a hypotensive patient who is not responding to resuscitation. So you've got a good, maybe a double IV cannula or a big bore central line. You push in a liter or even 2 liters of Ringer's lactate or normal saline into this patient. The hypotension doesn't get better. Or the patient gets initially better, a systolic of 70 or 80 becomes 100 or 110. And very soon, within 15-20 minutes after you infuse the fluid, it will come down to 80. The 100 or 110 systolic is not sustained. So he either has persistent hypotension or recurrent hypotension. When these two things happen, he is an unstable patient. So, Nikita, what do you do when you have an unstable patient on your hand?
We'll try to stabilize himself, like whatever the parameters are low, we'll try to correct them.
The definition of unstable, I've just told you, you're not able to stabilize him. I've just said that.
Manage.
Sorry?
Do an
Midline
e-fast and
necrotomies.
shift to OT.
Yeah. Do you have to do an e-fast?
Yes, sir.
But suppose you can't do the e-fast and he's so hypotensive, what do you do?
Intubate the patient and
No, you have to
Patient will
shift,
be
sir.
shift the patient to OT.
Yes, sir.
All right. That's all there is to it. Okay. You have a primary survey and a resuscitation. No time for secondary survey. You have either you can do a DPL. You can't get an e-fast quickly. If you get it, fine. As I keep on saying, as you're doing a primary survey and resuscitation, get an e-fast. All right. As you're doing it, they have to happen simultaneously. For some reason, you cannot get it. Don't wait. Take the patient to OT. Call them and take the patient to OT. Do a laparotomy. Put a laparoscopy because only, and that too, please note that it is in very small letters. People, there are enthusiasts who are recommending it, particularly when you have not done a DPL or an e-fast. Okay. Some people say, and if the patient is well enough, I agree. Just put a laparoscope in the OT. Don't waste time in the casualty. Shift him to the OT, induce him, do a quick laparoscopy to make sure there is a lot of blood in the peritoneal cavity, and then do a laparotomy and proceed. You cannot do the definitive procedure with a laparoscopy when there's a lot of bleeding. All right, that may be the role for laparoscopy. But if you don't want to waste time on laparoscopy, it doesn't matter if you have a negative laparotomy. It will be extremely, extremely rare for you to have a negative laparotomy. Do a laparotomy and deal with the bleeding. That's what you need to do. That's why I have put this jumping arrow here. It's not necessary to always try and get this. If the patient is unstable, have a very, very low threshold to shift the patient to the OT. Okay. Any comments so far from the teachers?
Sir,
In fast, it would be negative.
Sorry, if the fast is negative, yeah.
And the patient has abdominal distension.
Yeah.
It is indication for laparotomy.
Yeah, definitely at least a laparoscopy. Yeah, as I said, a negative fast is not completely reliable.
sir,
Yeah, go on, buddy.
sir, one thing is if the patient is unstable, you are trying to resuscitate them. Will a quick CT running them through a CT to give you a hint, because sometimes there may be chest injuries which may not be picked up.
Absolute no, Ravi, because these patients have died in the CT chamber. There are many, many instances where in the process of shifting or in the CT, module, in the CT area, people have died. So it's very, very important that you do, if they are unstable, either you do whatever you have to do in the casualty, and if you cannot do it, take them to the OT. That's a very clear direction that is there, because as I repeat myself, in the process of shifting them to the CT, they have died.
And sir, about DPL,
Yeah.
I think probably it is mentioned to be given up. I think almost certainly I think it's not done, because I think ultrasound is available almost everywhere.
That is a question. It's not available everywhere. Okay, for example, if in SHRC today in the center of Bangalore, I can't get a e-fast if I have an injured patient. It may be available in Sagar. Many centers outside Bangalore do not have a 24/7 ultrasound service. Almost many places don't have an ultrasound service. That's why DPL has its role in our kind of healthcare setting. Yeah. Okay. So when we come to the stable patient, you don't have to rush to the OT. The patient you have resuscitated them. You have to investigate. Right. So what is the kind of investigation that you would have?
CT, sir.
Go on. Straight away CT?
Sir, you will do e-fast and then CT, sir.
You don't need to know the patient's hemoglobin?
Routine, all the routine investigation.
You have to start with that, no?
Yes, sir.
All right. You have to start with the routine investigation. You want to do a plain X-ray. There is a role for ultrasound, a role for CT, and a role for laparoscopy. Okay. These are the things that one can consider, and we look at what each one of them will tell you, whether it is useful, not useful, it should be done or not done. Okay, laboratory tests are generally unreliable, but nevertheless, all the patients must have all this. There's no, because it at least serves as a baseline. It is important for you to know that it's good to have the patient's hemoglobin, hematocrit as a baseline. PT, INR, coagulopathy, pancreatic injury. Please note this in very big letters that I have written. Generally unreliable, but to have a baseline, you cannot do without them. Very important in, childbearing age, good to have a pregnancy test. Because a lot of things you might be doing without taking the patient, without being able to take the patient's history. So it's good to have a pregnancy test and blood gases. This is something that you have to do, even though we know that it has its limitations. Now, is there a role for plain X-ray? If so, what would you do? Go on, Vinod.
Direct X-ray abdomen,
Okay, and
chest X-ray.
okay, and
Pelvis.
pelvis. Chest X-ray and pelvis are the main things. Erect abdomen X-ray is how practical is it in a badly injured patient to get an erect X-ray? Not possible. All right. Yeah. So you get a chest X-ray and you look for possible fractured ribs, hemothorax, pneumothorax. That itself will tell you gas into the diaphragm if there's a hollow viscous perforation, and foreign bodies if any. Okay. And a pelvic X-ray is very important. Abdomen and pelvis. It's important. Ground glass. If you have a lot of blood or a lot of bowel content, it will be a ground glass. Integrity of pelvic ring is something that you must carefully look for. Fracture pubis must warn you about possible urethral or urinary bladder damage, and foreign bodies, particularly in RTA. If there's a penetrating element to the blunt injury, then you must be looking at that as well. But of much less importance than FAST or CT. Okay. Now we talked about FAST, but there is also a standard detailed ultrasound examination. I've already mentioned that it is a limited role, but what are the things that you look for in that? Nikita.
Internal organ injuries,
Sorry?
like spleen, liver,
Yes, solid organ injuries. How sensitive is it for that?
around 70%, sir.
Yeah, much less actually, but it's not very sensitive. Go on. Go on. What else?
And any rarely, sir,
See,
pancreatic injuries we can.
yeah. Pancreatic, please don't mention it. If there's something that you cannot see in ultrasound, it is pancreas.
Yes, sir.
Even in a normal, in a non-trauma patient, keep on. How can you make this statement, Vinod? We keep saying ultrasound cannot see pancreas, even in a non-injured patient. It's much worse in a non-injured patient with an abdominal
Sir, but in a
distension.
pancreatitis patient, we will see, right, sir?
Ultrasound, you depend on ultrasound for pancreatitis?
Because there is a pancreatic collections and
I
heterogeneous.
understand, but do you depend on it?
No, yes, sir.
Yeah, that is the point. Sensitivity. I'm not
Yes,
saying
sir.
you cannot see at all, but would
Yes.
you believe an ultrasound report for pancreatitis? No, you do not. It is a CT. Okay, please don't get confused about it. Anyway, you look for free fluid, but scoring is important in the sense they tell you whether it is mild, moderate, or marked, severe fluid collection. Parenchymal injuries, you said 70, the actual fact is 40%. Not very important, but serial sonography, as I keep saying, helps because from one point to the next, an hour later, there may be a larger amount of fluid which they can pick up. And we always say this, observer dependent, obesity, it precludes proper examination. And also remember, if you have a lung injury and you may have subcutaneous emphysema coming right down, going up into the neck from the chest and coming down into the abdominal wall. So these are limitations. And so ultrasound per se has a very limited role. So after a fast, if the patient is stable and you find that there is blood in the peritoneal cavity, the thing that you do next is this. CT is the gold standard in stable patients. All right. So what do you look for in the CT? Samir, have a go.
Hello.
Go on, go on. All right. So please note this this URL at the bottom. I'll put this. I'll put the PPT in a group, and don't forget to look up this URL, radiology assistant, CT in trauma. Very, very nicely and succinctly given page on that. Okay. So CT is very useful in initial assessment of stable patients. Unstable patients, don't send them to CT. Of stable patients, usually prefer to do it with an IV contrast. Repeat examination 6 to 8 hours later may be considered if you're still not sure of what's going on. And when you have done a conservative treatment for a liver or a spleen injury, it is probably wise to do it to look at the status of the subcapsular hematoma or fluid collections or whatever before discharge. And special interest of CT, we're talking about abdomen, so I'm adding these two, is to do a CT of the chest to rule out a concomitant chest injury, and a special KUB study, because renal injuries and bladder injuries are something that we need to bear in mind. You presented that case of a missed bladder injury. It's very easily done. It's not that there was a problem in what you did, but we must remember that a bladder injury can be easily missed, and so it's good to have a KUB study. But look at this little picture, which is very, very self-explanatory. So when you do a CT, it tells you so many things about fluid in the peritoneal cavity, laceration of solid organs, devascularization, where you can get an area of, lack of circulation. Necrosis, might not have gone into necrosis so soon, but it tells you, because you're given IV contrast, that part of the solid organ is not perfused. You can appreciate pneumoperitoneum, you can actually appreciate active bleeding. How does active bleeding look to you on CT, Samir?
There will be evacuation of contrast.
What is that called? You're right. What is that process called? It's not called, what did you call it? Extravasation.
Yes, sir.
It's not that word, it's something else. It's called a blush. Okay. So
Yes.
you have, perhaps you can even see a blood vessel going across some point, but you will have a blush or a hazy area, which is because of the extravasated contrast. Okay. It's called a blush. And so that shows that there is active bleeding. You can have subcapsular hematoma of the liver, of the spleen, or the kidney. Okay. All these can be seen, and it is quite accurate as well, because the imaging gives you a kind of sensitivity over 85 to 90%, specificity about the same area, in the same ballpark. And so CT is the gold standard. You can consider angiography, again, if the patient is stable, but that is debatable. But what do you do in angiography? Nikita?
So we
Where do
usually
you
see
use
whether
it?
the
Where do you use it? Okay, it has to be in two areas. Okay, it has to, isolated use of angiography is useless. It has to be with embolization. Okay, and you can use it in certain grades of injury of the solid organ of the liver and spleen, and in pelvic fracture. All right, in pelvic fracture, you know that there's a huge retroperitoneal hematoma because of the fracture and the involvement of safety veins. Angiography, you can embolize and try and control that bleeding to some extent. Okay, so these are the two areas where angiography can be considered, but it is still debatable. Still debatable. Okay, and once we talk about trauma, all right, we always talk about the lethal triad, and that's something that we must always, we cannot, as surgeons, we cannot be only focused on the anatomical structural damage. We must also be thinking about the metabolic issues. So what is this lethal triad, Ines?
So it is acidosis, then hypothermia, and
Coagulopathy.
coagulopathy.
All right?
Yes,
Yeah.
sir.
So
Yes.
this is very important. Now you go back and you look at the blood investigations I asked for. Okay, PT, PTT, INR was one of them. Platelet count. Okay, and these are things that you have to bear in mind because coagulopathy is a very real possibility in these. And the other thing that it leads to as a surgeon, okay, as a surgeon, because you're worried about the lethal triad, okay, you take certain decisions in your operations in an unstable patient. What is it that I'm talking about? What is it that should make you think when you're concerned about the lethal triad coming into play in a given patient?
Damage control study.
Sorry?
Damage control study.
Excellent.
Surgery.
Okay, correct. That is something that you should be worried about. You should be thinking about. Okay, correct. Damage control surgery. And that is something we will be talking about in a little while. So when we are looking at a stable patient who is resuscitated, when would you offer them conservative management?
If the trauma scores are less and if there is no active bleeding, sir,
Okay,
we can wait
that's
and
one.
watch,
Okay,
observe further.
okay,
And
When
vitals are
solid
also
organ
stable.
injuries like grade 1, grade 2, grade 3, sir.
okay, good. What else? You can't stop so quickly. Okay,
And so there's no
let me put it this way. The let us say you treat everybody conservatively, but there are certain contraindications for conservative management, which necessarily become the indications for laparotomy. You understand? So, what are the contraindications for conservative management, or in other words, indications for laparotomy? That's what I need to know. One of them you said is active bleeding. Agreed. You have resuscitated. You have higher degrees of solid organ injury, which you have determined by CT. Agreed. What else?
Recurrent hypotension, sir.
Yeah, that is continued bleeding. It's the same as continued bleeding. That
And
is an unstable patient.
yes, sir.
Peritoneal irritation here. Okay, if somebody is guarding and you're looking at, when you say peritoneal irritation, it is basically a pneumoperitoneum and a
Peritoneum.
bowel rupture. Okay, apart from bleeding, the only other thing that can happen is a hollow viscous perforation, peritonitis because of bowel contents leaking into the peritoneal cavity. You can't sit on a diaphragmatic rupture, all right, or a persistent significant GI bleed. It's a rare thing, but you can have organs which are torn and which can keep bleeding into the GI tract, apart from into the peritoneal cavity. That's another possibility. You can have a big hemophilia in a ruptured, in an injured liver, for example. So persistent or a significant GI bleed, evidence of diaphragmatic rupture, pneumoperitoneum, signs and persistent signs of peritoneal irritation, and an unstable patient because of hypotension. These are the indications for laparotomy or contraindications for conservative management. That is something that you have to have in mind. But if you're doing a conservative management, please make sure that your hospital where you're working has a facility for proper constant monitoring in an ICU or an HDU. You have adequate blood available. If you can't arrange blood quickly, you should not be doing a conservative management, and you have a 24/7 OT availability. Okay, don't assume that every unit, every hospital will have all these things. It happens. I know it's available in Sagar, but every hospital cannot be, claiming that kind of backup. And so you need to be aware. And if you're a surgeon working in a periphery where these things are not available, you must make arrangements to shift the patient to a place where it is available. Or if that is also difficult, better to do a laparotomy. Do a laparotomy, look inside, even if it's a negative laparotomy, it's okay. The patient is safe and you can sleep well. Okay, that's a strategy that you must have. And we talked about damage control surgery. Ines, what is damage control surgery?
So you like staged intervention is done, sir. Like
What is
you do
what is the purpose of damage control surgery and what are your main objectives?
So, like you do the first is to minimize the surgical time and to control in that duration to control life-threatening injuries.
Control what?
Life-threatening injuries, sir. Like
Why are you beating around the bush? What are the two things that you control when you're doing damage control?
so hemostasis
Correct.
is
Bleeding
one
and
thing, and like stabilization of
Contamination.
the
that's all there is to it.
contact.
There is nothing magical about damage control. I'm sorry, it's already 10 o'clock. I think I'll quickly go through it, finish the thing. Otherwise, it could be, yeah. The thing that you do is control bleeding and control contamination. So bleeding can be controlled in many ways. I won't go into the detail. You do not bother about definitive surgery. If sometimes controlling contamination means you cannot do anything with the torn bowel, just tie it up. Make sure that it doesn't keep on spewing bowel content into the abdomen. Pack the abdomen and get out. Okay? Do a laparostomy. You can't close that abdomen. Do a laparostomy, an open abdomen, and get that triad corrected, coagulopathy, acidosis, and hypothermia corrected. The patient hopefully lives for you to go in again, maybe 12, 24 hours later to do the needful. And so, as soon as you do these three things, you stabilize the patient in the ICU and re-explore. Be ready to re-explore the very next morning if required. Okay. Now, individual organ injury, I'll just run through this in the next 10 minutes and then we'll close the discussion. There are many areas can be damaged. The spleen, liver, pancreas, bowel, retroperitoneal bleed, major vessel, aorta can be damaged, diaphragm, kidney, bladder, apart from the bone injury, fracture of the spine and the pelvis. Okay, many of these things can happen. I'm going to just give you the very basic outline, and if you are interested, we can have another class on the management of individual organ injury. Okay, that is something which perhaps you may want to learn about the technique involved, in which case we will have another class. Okay, bear that in mind, Sanya and Nitya. And you want to line me up or Ravishankar up for one of those classes, you can ask for it and get it done. Okay, for a splenic injury, you always have a CT grading 1 to 5. So is the case with the liver. Please look it up. You don't have to mug it up. What it tells you basically is that if you have just a subcapsular hematoma, a small one with a small laceration, okay, with or without a capsular tear, it is grade 1. If it is a little more, it is grade 2. These are suitable for conservative treatment. If you have the next level where a larger area, half this spleen is covered with a subcapsular hematoma, it could be ruptured and there is a hematoma in the parenchyma, but this hilum is intact. The major vessels getting into or draining the spleen are still intact. The hilum is intact. If that is the case, you may consider angiography and embolization if the facility is available. But if it is grade 4 or grade 5, where hilum is involved and there is major devascularization and the spleen is shattered, then you have to consider surgery. You do your best attempt to preserve the surgery. Partial splenectomy has to be done, and in my experience, in the large majority of cases, you can do partial splenectomy. But if it is really shattered and you can't do anything about it, you may have to do a total splenectomy. That is also acceptable. Liver injury, similar liver injury scale is there based on your CT. But please note, unlike in the spleen, the injury grade does not necessarily influence your management, but it does tell you about the morbidity and mortality. The reason is that the liver is a much bigger organ and you have perhaps more ways of controlling the bleeding there than in the spleen. And because it's a bigger organ, even the so-called smaller grades can give rise to simple, bigger bleeding. And so don't go too much with the grading as far as your treatment decision is concerned. You go more by the hemodynamics of the patient and how the patient behaves over the next 12 to 24 hours. You must have a low threshold for laparotomy. What you do if you do bleeding, when you encounter bleeding, is something which we can discuss later. As I said, you can have conservative treatment. In fact, a large majority of liver injuries, like splenic injuries, are managed conservatively today. You can consider embolization and the operative management. In the operative management, you can have 4-quadrant packing. This is not exclusively for liver. It is a very badly bleeding patient who's unstable. You can't even know where the bleeding is from, and you want to resuscitate the patient. Then just do a big laparotomy, big cut from top to bottom, exifisternum to the suprapubic area if required. Pack the whole abdomen with packs, 4-quadrant packing, and then just wait for an hour or so, wait for the anesthetist to resuscitate. And then when you keep on slowly removing these packs, it's always recommended that you remove from the pelvis to the abdomen higher up, because the most likely major bleeds are from the liver and the spleen. So, if you start removing it from the pelvis, you'll perhaps look at some pelvic vessel or a mesenteric vessel, direct suturing. The liver, as I said, Pringle maneuver is one possibility. You can keep it clamped for an hour. Retrohepatic bleeding is very tricky. I've had 2 of these cases, but we could suture it. Hepatic avulsion of hepatic veins, we could suture it. You can then consider what's called venous isolation, where you put, isolate above and below the hepatic veins, where as it joins the inferior vena cava, and then you can suture that laceration of the hepatic veins. In large shattered livers, you may consider a lobectomy. People have described extracorporeal circulation, usual bypass that people have in cardiac surgery, and liver transplant for trauma. But as you can see, these are extremely rare. I put it in very small letters. Pancreatic injury, please remember, isolated injury is very rare. It is a package. When I say package, I mean several other organs are involved, most often spleen, stomach, and duodenum. And it always denotes a very severe force. So the patient is severely injured, often missed, and it's a big controversy. It's a big dilemma, not even a controversy, as to what to do when you find retroperitoneal hematoma in the area of the pancreas. Now, the standard teaching for retroperitoneal hematoma is that don't cut the posterior peritoneum, because the intact peritoneum has caused tamponade and stopped the bleeding. So if you cut open and remove that, then it ends up being a free intraperitoneal bleed, and the bleeding may start again because the tamponade effect is gone. But in the area of the pancreas, it's an issue. Okay, it's difficult a decision to make. If concomitant duodenal injury is seen, not much of a difficulty. You have to go ahead and open it up and see what happens. Otherwise, sometimes because you're reluctant to open the posterior peritoneum in front of the pancreas, you may miss a ductal damage. If the pancreatic duct is disrupted and you miss it, then you can have consequences. Okay, so the options are many: conservative management, simple drainage. If you find that it is just bleeding and nothing else, simple drainage can be done. You can consider duct stenting, even endoscopic, if the duodenum is intact. And you may have, sometimes in bad injuries, you may need either distal resection or a Whipple resection if there is an involvement of the duodenum also. Exactly what you do is something that we will discuss in a subsequent class. Bowel injury, you can have various kinds of injuries. Contusion, you can wait and watch. But remember that this contusion may lead to necrosis and perforation 3 to 5 days later. So they have to be watched very carefully. If you're in a damage control situation, you can't even exteriorize. Sometimes it's so bad that you can't form a stoma. In which case, don't worry, just tie it up. Just tie it up and make sure that the free flow of bowel contents are not flowing into the peritoneal cavity. You can always stabilize the patient and go in 24 hours later. If you have a laceration, you have the choice of a repair resection, or exteriorization of the area, depending on where you see. What you must know about mesenteric tear is it's perhaps very easy to stop the bleeding with ligation, but always look at the consequences. Will it lead to a vascular compromise of the bowel? That is that part of the mesentery is supplying blood with. That is something that you always have to have in mind. If you are in doubt, the patient is stable, resect. Patient is not stable, just stop the mesenteric bleed and go in 24, 48 hours later to look at the state of the bowel. Okay, and these are, I know that I've run through the whole thing, but my primary focus in this talk was to talk to you up to the point where we were discussing the individual organ injury. That is something that if you have, in mind, then the purpose of this discussion is served. Penetrating injury again is another topic by itself. And as I said, I'll let you read through this for half a minute. You have to first know whether that penetration is through the peritoneum or not. It is the mechanism and the consequences are different, whether it's a knife or a bullet or a blast injury. The blast injuries are perhaps the most devastating and the most complex of injuries. We must discuss it sometime. I've given the 5 possible areas of damage in a blast, but I think we should discuss, even though we don't see it often, even with civil strife and bombs and terrorist attacks, as surgeons, we must know about it. So I think it's worth having a discussion later. Okay, I think this is my last slide. Yeah. Thank you very much. I'll now invite the students to give their comments and questions, and then we'll move on to the teachers.
In a trauma patient is stable, when to decide on CT, sir? I mean CT.
Straight away. If the fast
Every
tells,
patient, sir?
every patient, if the fast says that there is blood in the peritoneal cavity, okay? If the fast is negative and the patient is stable, then there's nothing. We don't have to do any further investigation. Admit them in the ward and watch them. Repeat the fast.
Sir, what I mean is every trauma patient, sir, whether the patient complains of pain abdomen or not.
No. I'm just explaining it to you. The trauma comes in so much variation, so many colors and shades that you have to individualize. There's a patient with kicked in the abdomen or had a handlebar injury on a scooter, comes to the casualty. Okay, patient is stable. You do a fast. There is no blood in the peritoneal cavity. Pulse is 80. BP is normal. Why do you want to do anything? Keep them in the ward. Observe them just in case you may have some problems. Okay, do a fast. No blood, no CT, no nothing. But the patient comes.
I'm asking this because of medical legal things, sir. That's why.
Even medical legal also. I don't think every patient who comes with history of trauma needs a CT. But if the patient is hypotensive, there is blood in the peritoneal cavity or fluid in the peritoneal cavity, definitely get a CT done.
Yes.
Yeah. Very clear. Just because of medical legal reasons, you need not get a CT. Ravi.
I think, sir. Yeah, I think it's individualization of treatment and assessment, reassessment, not only of the abdomen, of the whole patient. I think all those messages are very clear, sir.
Okay. There are no other questions from students. Comments from the teachers. Srikanth.
Multiple liver lacerations, persistent wounds.
Yeah.
Whether can suture it or pack it or.
Yeah. There are 2 options. Deep parenchymal sutures. There are actually, 45 needles. Okay. You can take deep sutures and sorry?
Pledge, if you get pledgets also.
Put a pledget or a piece of omentum into it and stitch it up. That is possible. Or you can just drain it if it's just a minor ooze. Drain it and get the coagulation corrected, and that itself may do the job. Or if you have multiple small area of the liver associated with multiple lacerations, you can do a partial hepatectomy. It can even be a non-anatomical resection. That's not ruled out. In trauma, you can do a non-anatomical resection.
No, I just want to know whether suturing is advisable.
It depends. It's very, very individualized. If there are 3 or 4 lacerations, for example, you can suture it. If you have 15
What's the material
lacerations,
used, sir?
catgut. There's a large blunt. It's not even that. I don't know if you've seen those needles. I've used those.
No.
Large
One case we did
needles.
in Sagar. That's why me and Munra did.
Yeah, large needles with a blunt tip. It's not even a sharp tip. So those are just driven through in the depths of the liver and sutures are taken. And because you don't want it to pull through, you can either put platelets, of Abgel, for example. You can use that as a sheet of Abgel, or you can put a piece of omentum so that the suture that you put doesn't tear through. We can discuss this in another class in detail, various options.
Okay.
Yeah. All right. Niranjan, your comments? All right. Maybe it's not there. Ravi, your final comments before we close.
I think you've given a very comprehensive yet very succinct approach to trauma in general and abdominal trauma in particular. I think the point that you made about abdominal trauma is never isolated is very important for the understanding of the PG students, that they have to look at other things, other organs, and carefully examine the patient in total rather than just concentrate on abdomen. The one thing I would say is, if you are called as into the casualty, I think the surgical registrar, whoever is there, or surgical resident, should take the lead and be the leader of the trauma team, unless the casualty medical officer, who is very good, is there. Then and coordinate the management of the patient. That will make you confident and also manage the patient very well.
Agree with that.
It's a good class.
Okay. Thank you. Thank you very much, and good night, folks. Yeah.
Good night.